始まりましたね。
We are live, ladies and gentlemen. Good evening if you're joining us from Asia. Good afternoon if you're joining us from Europe or Africa. And good morning if you're joining us from the Americas. Welcome to Kenji Ojima's 5th YouTube Live International, all in English. Thank you all for coming and joining us today. Some of you may be joining us later and missing this introduction, but if you have a chance to watch it on replay, I'd like to express our deepest thanks once again for helping us make this effort so successful and choosing to spend the time that you have at home productively learning with us. These are hard times for everyone. We are all hoping for the quickest return to somewhat normality as possible. But in the meantime, we are ecstatic that you have chosen to spend your time learning with us. Now, at the same time that we are broadcasting live right now, the American Association of Orthodontics is also showing their presentations, or some of them anyway, online. And if you're here with us, that means that you are interested in an interactive conversation. Of course, those presentations, the difference between most major academic events and our at-home conversation is that not only do you get to see and learn from a master, but you get to interact with him. Now, if you've forgotten, my name is Robert, and I will be your host and MC today on this 1-hour journey of learning. And joining me, as always, is world-famous orthodontist, Invisalign master, Black Diamond Invisalign aligner provider, Dr. Kenji Ojima. Kenji, how are you?
How are you, Robert? How are you? So today is a very hot day, right?
It was very hot today. It was 35 degrees today. Very, very hot. I was amazed. Did you spend any time outside today?
Yes, I'm just for the walking for the both of the clinic, but today the both clinic is cannot treat for the patient. Just how I say emergency reaction,
right,
and calling for some patient, and sometimes is a teleworking relationship,
right?
And
okay.
Seminar, right?
Yeah, if anyone watching us isn't aware, Tokyo and most of Japan are under a national emergency situation, but there are no laws keeping us from going out and conducting emergency business. So in Kenji's case, when he had patients who just absolutely needed to see him today, he could see them. We are fortunate in Japan to have a little bit of flexibility, and hopefully, even with this flexibility, Japan can recover from this hard situation.
Yeah.
All right. So, Kenji, we have 2 amazing cases today.
Yes.
What are our 2 cases? What's our first case today?
The first one is open bite approaching, but not only upper molar distalization, so that we use for the mini screw with aligner, then lower molar distalization, the both arch, then so the intrusion, distalization molars, then finally we want to counterclockwise rotation of the mandible, then control of overbite approaching.
I see. So we covered mesialization in our last YouTube Live International, distalization a bit the one before. We covered mini screws in our last YouTube Live International. So today is sort of an integration of many of the exciting topics that we covered before.
Yes. Okay.
Excellent.
Let's go start.
All right.
This topic is a class 3 open bite patient, upper anterior extrusion. And this patient, 27 years old female patient, problem is that we have to think about distalization, not only upper side, so both of side, lower arch, lower molar too. So that is a very difficult movement, lower molar majoralization, lower molar distalization. This is our categories. So this is Kenji's categories. Me and our team and Ravi, Professor Ravi Nanda from University of Connecticut, our team published on the Journal of Clinical Orthodontics. Then so that at this time I explain like this. So many of the doctors talk about is open bite is just one of the difficult approaching for aligners.
Right.
Then we divide for the category level 1, 2, 3, 4, 5. Okay. Level 1 approach is only anterior extrusion, so the molar side is don't move anymore. Molar is angled. Level 2 is anterior extrusion plus molar intrusion. Then we want to control lower molar intrusion. Then we want to control counterclockwise rotation on the mandible. Level 3 is anterior extrusion with molar intrusion plus upper molar distalization. This is we call level 3 aligner open bite approaching. Level 4 is anterior extrusion plus molar intrusion with extraction. This approach is level 4. We call level 4. We call level 5 molar. Level 5 open bite approach for the aligner is anterior extrusion, molar intrusion, lower molar distalization. Sometimes we use minuscule TAR, temporary anchorage device. Okay. Today I want to show with you, share my experience for the level 5 approaching. Level 5.
How exciting!
Yes, this is one of the very difficult approaching for the aligners. Not only aligners, for the any kind of the approach is very difficult, lower molar distalization. Okay. So initially, I want to share like this. Initially, not only anterior extrusion, lower molar distalization, molar intrusion. We want to counterclockwise rotation on the mandible. Then solution like this situation. Okay. The open bite. So that many of the doctors don't think about aligner can possible tooth movement, molar medialization, distalization, intrusion. Okay. This is distalized for the lower molars and the canine. The last international YouTube live, so already Robert told us for the lower molar medialization. The doctor don't see. But this is an opposite to us. No problem. No problem. So this is an opposite approaching. Okay. Molar distalization with any thought. Now, he is my mentor, the Professor Ravi, so from University Connecticut, Orthodontic Department. He is my mentor. So I'm very exciting his article. His art, one of the many of the articles he published already, but this one I'm very excited. This is for the normally, so think about biomechanics. For the also open bite approaching. Very important thing is not only anterior teeth approaching, very important thing, the molar intrusion, counterclockwise rotation of the mandible, then solution. Okay. Basically, this article, then integration to aligners. This is initially molar intrusion, anterior extrusion, then lower molar distalization, the finally canine retraction, anterior retraction, then this is a final situation. So that is many of the type is a tooth movement. This is a level 5. Very important thing. Anterior extrusion, lower molar distalization, intrusion. This is the initial situation for this patient. This is a definitely class 3 situation, lower molars on both of sides, and the class 3 canine relationship and anterior open bite. The midline is just a little bit shift and a little bit canting, and the overbite is not good. And the lower anterior is a clouding. The 41 and 31 is just rotation. This is the initial situation for this patient. Okay. Then after that, so this patient is another one problem is upper second molar is not good root canal treatment, and the upper second molar is not good for the crown. This is the profile. Okay. This is an initial situation for this patient is cannot for the close the mouth, and sometimes is want to just a little bit tension his chin and not to go smiling for this patient. The one of the chief complaint is want to correct the big smiling after orthodontic treatment. This is initial situation. You can see that this is a curve of speech and not good and the skeletal open bite, then my planning is this is upper second molar, the right side is not good root canal treatment, not good crown insert. Then so my planning is extraction upper second molars. Then we want to distal movement for the upper first molars. Then so that we want to control upper right wisdom tooth. But you can see this wisdom tooth is just a little bit small size. The finally end of the also we have to need prosthetic approach.
Okay.
This is initially, and this is we have to think about anterior extrusion. Anterior extrusion, then we have to think about which position is better smiling or not for this patient. At this time, we use for the digital smile design protocol, the face, photos, integration, clean check, then we understood how millimeter extrusion is better smiling or not. That is very important thing. If only think about clean check, only think about tooth, nobody understood which position is better smiling or not. Okay, so we all the time think about decide on the final position first, then go back to the clean check. This is my final situation. So planning is alignment, the angulation, and the smile curve is expansion canine to canine. Expansion canine to canine 4.0 millimeters. Extrusion anterior teeth 5.0 millimeters. Extrusion for this patient. Okay. This is my planning. Then started tooth movement. Molars is distalization, lower and the upper side, and additional place on the miniscule tart. Then distalization, lower molars, premolars, canine, finally clockwise rotation on the mandible, then biting. This is my planning. The face integration clean check. Then we understood 5 millimeter extrusion anterior teeth, 4.0 millimeter expansion canine to canine, and place on the tart, then distalization, lower molars, upper molar 2, and of course at this time, intrusion the molar 2. Intrusion, distalization. So this is a very, very difficult approaching for the aligners and difficult to approaching for the molars movement, okay? Then so my protocol, so the very important thing for the extrusion anterior teeth is a place on the bevel type attachment. This one is bevel type attachment. This attachment is very effective to the upper anterior teeth for the extrusion. So I all the time select the bevel type like this, or some of the time rectangular attachment.
Why is it so effective for extrusion? Why is this specific shape so effective for extrusion?
Because this is very easy to weigh. Is the big face is an active surface, easy to pushing to the aligner for the teeth. Then we can easy to control extrusion tooth movement.
I see.
Very nice question. That is very nice question. Then same time, 1, 2, 2, 2, 2 is the same time extrusion. Alignment, then so after molar distalization, premolar distalization, then canine retraction, anterior for incisor retraction lowers. This is the initial OPG. This is my planning extraction. Upper side is both of sides second molars. Why I extraction decide on upper second molars? So the right side, I already told you, not good root canal treatment, not good crown.
Right.
Why we decide on extraction second molar is second molar, upper second molar left is a big inlay insert and not good for the situation. And the wisdom tooth is very easy to eruption. This axis is very easy to eruption, naturally eruption.
Okay.
Then I decide on extraction teeth is 1.7 and 2.7. Okay. Lower side is we select for the third molar wisdom tooth. This is my approaching. Then initially you can see for the upper right second molar is big crown insert. Okay, I will just move here. Our face just a little bit move. Here it's good.
I feel comfortable here. Thank you.
Then so that you can see upper second molar is a big crown, and the upper left second molar is a big inlay insert. This is not good for the tooth situation. Then I decide on extraction both of these teeth. Okay. Then place on the attachment. You can see the post extraction upper second molars, upper left second molars. Then we can check already started to eruption wisdom tooth for the upper teeth. Started to the extrusion anterior incisors, started to intrusion upper molars, lower molars. Extrusion upper anterior teeth too. This is same time we do like this. Then we started to the leveling phase. So the upper arch is almost good for the leveling, and the lower side is you can see is a distalization. Then so the between lower second premolar to lower first molar is you can see create a space. Okay, this is distalization. But at this time we don't use any tat, only aligners, because you cannot see minuscule. Okay. After lower molar distalization, then we place on minuscule. You can see the both of side is placed on the minuscule between lower left first molar and the lower left second molar. And the lower right side is a more bug, cannot see minuscule, but place on this time for the minuscule. Then using elastic like this. Okay, why place on this time is initially molar is second molar distalization, then place on the minuscule is more, how I say, easy to control and prevent for the hit for the root from the minuscule. That is very dangerous. Move the second molar first. After that, place on the minuscule is more safety. Okay.
Makes a lot of sense. Finish the tooth movement before you place anything extra. That's smart.
Yeah, exactly. Then so this is more lower arch is retraction. You can see is a lower molars, premolar almost class 1 relationship achieved, and the upper anterior teeth and the lower anterior teeth. So the extrusion is almost is okay. Then we started to correction anterior clouding, and so that we still using class 3 elastic for the from minuscule to canine. Okay. And this is started to the detailing phase. So we achieved the class 1 relationship canine and the class 1 relationship molar side, and the upper left wisdom tooth is almost good eruption. Upper right small size wisdom tooth is good for the eruption, but not good position. Okay, eruption is good.
Okay.
Position is not good. Here is started to create space upper right wisdom tooth, because after alignment orthodontic treatment, and also order to interdisciplinary prosthodontist place on the crown for the ceramic crown. At this time we have to need to create a space between second. Yeah. This is a final aligner. Then so this is the create space, because after that place on the ceramic crown. At this time my planning is the minimum 3.0 millimeter space is very important thing. Here to here. Then after that, this is placed on the crown. Insert here. This is the crown. So that for specialty like this situation, please think about image. Like this small size teeth is very difficult to control braces, normal braces and lingual braces.
Right.
Because the crown size is very small, very difficult to bonding the braces. But the aligner is we can do any type of the shape. Yes, because gripping the aligner, we can control everything. But some of the time, so like this situation, braces, labial braces, lingual braces, very tough. But aligner, we can control precisely tooth movement. So my idea is create a 3.0 millimeter after that place on the crown. It's a very easy and a very precisely tooth movement because the aligner is gripping the teeth. We can control any tooth movement. Then this is a final situation for this patient. Finally is a midline correct, the canine guidance achieved, and the molar relationship +1 relationship. Then this is the end of the tooth movement. This is a comparison initial and final. So that we can do is aligners and mini screw and elastic. Finally, end of the also place on the crown upper right wisdom tooth. Then, so the tooth movement is good, but a very important thing for the patient is the smiling. Tooth position is good, but the very important thing, the face integration tooth position. Please have a look. This is cephalometric X-ray. This is the overlap. Is initial and the final. Is the tooth movement is very good. And this is very important thing for me. Is all the time take a photo with aligners. The aligner fitting is good. The tooth movement is completely perfect. So if aligner fitting is not good, is you cannot for the tooth movement is perfectly. So very important thing, we have to check precisely all the time, take a photo with aligners. That is the one of the very good, very important thing approaching. Okay.
Now, Kenji,
Yes.
are there any software that can recognize unfit? Looking if the software scans an aligner photo, or is that something that you must use your eyes for?
I use all the time the also communication software. So also communication software is easy to take photos. So directly smartphone, then upload, then finish. So that your staff and you is very easy to take photos and documentation.
I see. And then after you've taken the photos, you look at them one by one with your own eyes to check for unfit.
Yes.
Correct?
All the time.
I see. Okay.
But after Corona situation, so our team is we definitely strongly focus on remote control. So the also communication new function is started to remote communication function. That function is very amazing because the patient take a photo in the house with aligners. This take photos is automatically sent to the also communication software inside patient page. That is automatically.
Oh wow! Okay.
That is amazing. That is a new approaching after Corona time. Okay.
That's great. So they don't have to attach a photo and send it. They take it and it automatically uploads to the Ortho communication software. That's amazing.
That is a better way to the both of thing is one is a patient is good because a patient is don't need it come to the clinic. This is the benefit for the patient. And another hand is staff is good because the staff is sometimes very scared, very worried about it, like this situation. But take a photo in the house, automatically sent to the clinic is photos. I think the both of the very benefit and strongly, how I say, the good for the commercial for your clinic, I think.
Yes, for sure, for sure.
This is a comparison initial and the final and the facial situation. The initial is very tough, very, how I say, tight to the muscle. At the end of that orthodontic treatment is a very, how I say, no tension and smooth and relaxed and good for the profile. This is initial and final, and the very profile is good, and E line and smile line is good. This is end of the situation for this patient. Okay. This is a first case.
It's a fantastic case, Kenji. As usual, you have shown us exactly what kind of amazing treatments are possible if you know what to do with aligners. Ladies and gentlemen, there are around 50 people watching us right now. And just to remind you, the YouTube Live International is an interactive experience. So, of course, you can watch passively if that's what you'd like to do. However, if you have any questions or comments for Kenji, please put them into the live chat and we will respond to them as soon as we can. If you're new to our YouTube Live International, please take this time to like and subscribe. The more people who like and subscribe us, the more we grow this channel, the more high quality and more often we can provide content for you. So, we are now in between cases. Kenji has finished the first case. If you have any questions or comments, direct them to the live chat and let's discuss them. We have a comment from a Korean viewer. I'm sorry, I don't read Korean, but our Korean viewer says, good treatment planning.
안녕하세요. 감사합니다.
And I agree. Yes, and thank you so much for joining us from Korea. Okay, and it looks like we have a repeat visitor, Tamara Nichia, who comes and joins us almost every single YouTube Live International. Hello, Tamara.
Tamara, hello.
And Tamara says, konbanwa, sensei, konbanwa. Amazing case. So did the patient have any bad habits, such as mouth breathing?
Yes.
I imagine. So what did you do about the bad habit?
So very nice question, Tamara. So many of the time, so like this open bite patient is with bad habit, the tongue habit. So the many of the time is braces. So before tooth movement, we want to think about MFT, myofunctional therapy. So the training for the tongue and training to the prevent for the bad habit. So at this time, if using a liner is a more easy solution. So my approach is just a little bit cutting for the lingual aspect for the liners. This is not smooth. This is very rough. The patient is a very tough time hit for the tongue over the upper lingual aspect, a liner. It's very tough. And that is very easy to tongue training and very similar to tongue clip appliance. If you want so the control bad habit for the patient like this, at this time you can cut maybe 1 millimeter, just a little bit, 1 millimeter cut, so the between 1 and 2 only just a little bit. Only this patient very uncomfortable, then easy to control so the patient bad habit. Please try it, okay?
Oh, great. That is a fantastic piece of advice. Of course, when we focus only on tooth movement, we lose sight of some of the other important parts of training, like developing good mouth habits. And that is a great tip, putting a small incision on the lingual aspect of the aligner to create discomfort and do tongue training. That's fantastic. And of course, you do the cutting into the aligner yourself, right? It's not part of the ClinCheck order, right?
I do myself, just a little bit.
Great, that's great. Another insider technique from the master, Dr. Kenji Ojima. Well, thank you very much for your wonderful question, Tamara, and thank you for joining us again.
Thank you, Tamara.
Okay, let's look at our next question. We have a question from Dr. Wenhai. Hello, Dr. Wenhai.
Wenhai.
And Dr. Wenhai says,
Ni hao.
Ni hao ma. Dr. Wenhai says, hello, doctor. Do you include intrusion on the posterior teeth in this case?
Yes.
Okay, so
you can
do
see
you ask
now
the...
is now, so you can see is intrusion. So the initial one is yellow, so the final situation is green, so that you can see intrusion, the lower molars, upper molar too. Yes.
Okay. So do you ask the patient to bite on a chewy in this case?
Yes, so I love for the using the chewy, but the chewy is not too tough time, only few seconds. 1, 2, 3, 4, 5, only this. Not too much time.
Interesting.
I don't like for the too much time for using the chewy all the time. Only initial time. Finish.
So why do you not like to spend so much time with the chewy?
So initially is sometimes chewy is not completely perfect fitting. But using for the chewy is the fitting is much better, more better.
Okay.
And the aligner fitting is better, then easy to control the tooth. But sometimes the patient is not completely perfect for the aligner inside, just a little bit like this. If after that using the chewy aligner fitting more better, much better.
Okay, so just doing it once to fix the fit is enough. You don't have them chewing on the chewy all the time. Just once short time is enough.
Yes.
I see. Okay, so let's move on to another question. Thank you very much, Dr. Wenhai. And let's look at our next question. I'm sorry I cannot read the name, but our next question is, how is the intrusion of lower molars possible? How is this possible in this case?
Maybe Chinese Pongyo, Zhongguo Pongyo, right? Zhongguo Pongyo Ma. So how the intrusion of the lower molar is, yes, the lower molars, upper molar intrusion is possible to the aligners. So I definitely, so the molar control is better tooth movement, especially the aligner, because the aligners, we can use the bite force. Bite force, aligner is a cover to occlusal aspect. Then so the bite force is support to the intrusion, okay? So the lingual braces, the labial braces are not covered to the occlusal aspect. Only aligner, orthodontic appliance is covered to occlusal aspect, then more easy to intrusion. Definitely is a good tooth movement. But the very important thing is if you planning molar intrusion, molar majorization, molar distalization, at this time I recommendation before tooth movement, before planning, please take a cone beam CT data. You can check the bone situation and the molar situation. If hit for the cortical bone, very difficult to intrusion. At this time, we have to control like this situation, then intrusion is possible. But already like this, cannot intrusion, okay? Because this is a cortical bone, it's very strong, cannot for the intrusion more. But if control this, then intrusion is possible, okay? The Invisalign system is cannot understood for the root situation, the bone situation, only crown shape. So we need to take a cone beam CT before you are planning. Then after that, you understood tooth position, the bone situation, and the tooth for the axis. You have to need control. After that, intrusion is safety. You can do it.
Okay, fantastic. And thank you, Dr. Kenji. Okay, let's take one or two more questions before we move on to our next case. Welcome back, Dr. CMY. Hello, Dr. CMY. CMY says, hello, Dr. Kenji. Amazing case.
Thank you.
And how much molar intrusion is predictable with the aligner alone without TADs?
The specialty upper side and the lower side is I don't need for the any TAD. If I use for the molar distalization time, I support using for the TAD is meaning is support, anchorage loss. If only intrusion is we can do aligner only, so the 2 millimeters is no problem. Yes, but it depends on the bone situation. But if you want more, is using the TAD is more safety.
Okay, great. And we have a wonderful comment. Thank you as always, Dr. CMY, for your insightful questions. And next we have a comment from Dr. Asadi, who joined us in our last conversation as well, says, very professional as always, and many thanks for both of you, dear doctors, regarding my question in the last lecture about attachments. Yes, attachments are a big part of all of Kenji's cases that he's presented so far, and it is our pleasure to continue talking about them and explaining tips. Kenji is a master of deciding when and how to use attachments. And very often in his cases, he speeds through the attachment phase. So if you have any questions about specific attachment shapes in different situations, about timing and placement, please ask them. The only bad question is the question that remains unasked. So yes, we appreciate that you are learning from us, Dr. Asadi. Thank you so much. Okay, and let's take one last question before we move on to our next case. Our last question is from Fiona. Welcome back, Fiona. Hello again. Yes. I wonder if the weather is as hot where you are as it is here. I know that it is quite warm there always, but let's have a look at your question. Fiona's question is, how do you know if the tongue habit has been corrected? How do you know?
All the time I checking for the bite like this, and still open the lip, then insert for the water, then please drinking. This situation. They're not good for the controlled bad habit. Maybe the patient like this. But already good for the control for the bad habit. Patient do that still. All the time I talk to the patient, please training in your home, stay home this time. Sometimes watching
of course.
TV, sometimes watching on the smartphone. This time I explain like a bite, the spoon, the fork like this, and watching the TV, watching the movie, watching the PC at least 30 minutes per day. Slowing. That is
I see. So sucking in air and sucking in liquids, using the tongue to help train those tongue muscles.
So like this open bite patient is a very bad habit is like this. Then still open bite. So we want to correct and we want to training for the bad habit. So one approaching is like this, using the spoon 30 minutes per day training, tongue training. And I already told you the cut for the lingual aspect aligner is we create a rough surface. The patient very tough, touching the tongue. Then the patient want to right position of the tongue is a better way, but more comfortable. Then so we are two approaching. So training and cut it for the aligners. Just a little bit, not cut completely. 1 millimeter, less than 1 millimeter.
Right, like an abrasion, just a very, just creating some roughness on the inside of the aligner. So Fiona also has a follow-up question: is do we also have to cut out lingual cleats in the retainer as well?
Sorry, could you say again?
So it's from the same question. Part one is, how do you know if the tongue habit has been corrected? Part two, do we also have to cut out lingual cleats in the retainer? So do you cut the retainer also?
Retainer is, if still, how I say, still is a bad habit, is a better way, or sometimes yes, but normally I don't do that. The retainer is not. Because I already finished for the correct under control for the bad habit, then step up to the retainer's phase. That is more safety, right? And the robot is one of the Japanese for the attendees. Yasukochi Koji sensei. ありがとうございます。
Yes, he retracted his message after he said, 素晴らしいケースをありがとうございました. And you're very welcome. どういたしまして. It's our pleasure.
どうもありがとうございます。安浩二先生。はじめまして。
Nice catch, Kenji. Nice catch. Yes, well, before we get into our next case, I'd just like to say thank you again to the 60 wonderful viewers who are watching us. The YouTube Live International project that we're working on now has close to 6,000 views, and it is due all thanks to our loyal supporters like the 60 of you who are watching us now. Of course, the American Association of Orthodontics is having their own online meeting right now, and the fact that you've chosen to be with us just warms our heart. Thank you so much, and we hope that you enjoy the second case as much as you did the first. Kenji, we have one last question again from Koji Sensei in Japanese. Would you like to answer this question?
No, it's okay.
Or would you like
Please.
to Okay, so this question in Japanese is, again, thank you very much for the wonderful case. And
question from Dr. Yasukoji, right?
Yes, that's right.
Could you for the translation to the English?
I can try, sure. After extracting the lower right second molar, and were you able to use the lower right wisdom tooth in this case?
So the Dr. Yasukoji is another planning. He want to try to extraction. So the lower second molars, the same as upper side, right? Then so the control wisdom tooth. Yes, yeah, you are right. We can do it's both. Very nice idea. So yes, if you planning is much better to lower molar, second molar is extraction. So the control visualization lower wisdom tooth, third molars. Yes, it's possible. That is good.
Okay.
Both of them.
Great. Well, thank you very much for your insights. Yes, Koji Sensei, thank you very much. All right. So once again, ladies and gentlemen, if this is your first time joining us, hit like and subscribe, buckle your seatbelt, and get ready for our next case. Kenji, what is our next case today?
Okay, next one is teenagers. Teenagers approaching. The specialty for the aligner orthodontic treatment is very good for the teenager, young generation. I will show you. This patient is a 30 years old female patient. For teenager orthodontic treatment is very important thing. The three big keys is one is growth. We have to think about growth, and the second one is effective control of molar. Is we can do aligners. If aligner cannot move the molars, I never use this appliance. Aligner is a good control molars. Already you know is a last case is a molar, the distalization, intrusion. The same as this for the young generation, we can do molar control is very effective, very predictable. Then we can use aligners. The effective to control of the molar is very important thing. And finally is just hold on. Avoid extraction or not. If early started to tooth movement, especially the young generation, so that if we can possible avoid extraction or not, then we started to planning like this young generation. This young generation patient is a 30 years old female patient. The midline is correct, a deviation, and high canine, class 2 situation, and no space, and 1-2 alignment. The lower anterior teeth is just a little bit clouding, is not good for the contact anterior teeth. Then this is cheap complaint is 1-2 is in standing. Okay, and this is a OPG and safe for this patient. This is the clean check for this patient. My planning is already I told you, so the aligner is a good control upper molar, lower molar. Then we can do upper molar distalization, then avoid try to extraction for this patient. Upper molar distalization, then create a space, then alignment 1-2 and alignment anterior teeth. Lower side is same like this. Okay. This is my clean check. please have a look. Initially, place on the attachment started to distal movement upper molars, sequential distalization, then so that almost same time eruption second molar. Then this time is create a space, so alignment for 1, 2. Then started to alignment upper anterior teeth, control to the midline, alignment, so the control eruption, all the tooth. This is aligner with teeth. Aligner all the time fitting completely perfect like this. Then this is the final situation. End of the time is around 2 years for this patient. This is end of the time OPG and X-ray photos. So the tooth alignment for the parallelism is very nice. And this patient we can possible is avoid extraction. Then the specialty teenager is very important thing, not active tooth movement phase. And of the also we have to think about retain time. We have to check maintenance. 3 years later, this patient is alignment is good, the guidance is good, midline is good. This is OPG and the safe is alignment is good, no problem bone, no problem tooth. This is a 4 years retention for this patient. This patient already university student, is already adult phase, but alignment is good, the midline, bite position, all everything is good. So the specialty, my idea, my opinion is the aligner orthodontic treatment patient is good for the retention phase because already started to education first aligner is started to the education for the retainers. This is a totally different for the another orthodontic appliance. So my approach is the specialty aligner orthodontic treatment is very good for the control for the retention. Okay.
Yeah. Well, if the patient has been trained to wear an aligner for 20 hours a day, and they have 2 years of active treatment, retainment after that is just continuing the same habits. So you create good habits during the orthodontic phase, and those good habits carry over into the retainment phase. It's definitely an advantage to the long-term treatment effectiveness of aligners over other dental appliances. All right. So, Dr. Kenji, once again, a fantastic case. We haven't covered any teenage cases yet in our YouTube Live International. This is our first, and I hope that our audience enjoyed it. So, ladies and gentlemen, we've gotten to the end of this case now. If you have any questions or comments about this case, please go into the live chat and ask away. And of course, if you have no questions relevant to this specific case, but you'd like to ask Kenji about his treatment philosophy, or you have some burning questions about hot topics or divisive topics in aligner orthodontics, please go ahead and ask them. This time right now, this is your time. So please don't be shy. Get into the live chat and give us some comments or questions.
So the specialty like this situation, very important thing is a patient is still growing up. Growing up means is difficult for the size. The different size is a mandible. So the initially like this class 2 situation, so if doctor is want to distalize, maybe after 2 years later is situation is changed, sometimes become class 3. So the very important thing like this treatment time is we want to check precisely patient growth. Patient growth is very important thing like this. Okay, adult patient is no change for the mandible, as you know.
So, is there? Pardon me, I'm not very good with my biology, but for teenage patients, is there more mandible growth for males than females in the late teenage years?
Yes, it depends on how I say gender. Sometimes is
Right.
ladies is more faster is top speed of the growth about
Okay.
16 maybe, but male so man is just a little bit late. So the maximum growth speed is 17 or 18. So at this time we have to orthodontist we have to check so the growth and the toe size and the mandibular size we have to check precisely.
Okay. All right. Well, it looks like we've received some questions and comments. So let's get into our live chat and see what wisdom we can give out. We have a question from the orthodontic specialist, Dr. Stefan Decker. Hello, Dr. Stefan.
Stefan, thank you. Stefan is Germany.
Germany, maybe somewhere northern Europe, I'm sure.
Hmm?
Now, this is a question that your good friend from France, David, likes to talk about, right? How do you motivate teenagers to wear aligners?
So Stefan is thanks a lot for the wonderful question. It's very important thing, especially teenager, because the teenager is sometimes is not good for the motivation. So my approach is, especially teenager, where the aligner time is 16 hours per day. 16. So initially, adult patient is normally in my office is 20 hours per day wear the aligner. But young generation, especially young generation, we explain for the patient, please use 16 hours per day wear the aligners. What time we control management is waking up time, remove the aligner, then washing the teeth, eating and brushing, eating a breakfast, then go to the school. Okay, the school time is all the time fun time. Then back to the school around 3 p.m. or 4 p.m. Back to the home, then brushing the teeth. And mom watching the son or daughter, please start it for wear the aligners until the dinner time. Okay, the dinner time is remove the liner, after that brushing the teeth and wear again, then until the morning. Normally, so the younger generation is I use just a little bit short time wear the liners. But some of the patient, the younger generation, I want to wear the liner more. No problem. Okay, please do it 20 hours per day, or wear the liner, then go to the school until the lunchtime, wear the liner. After the lunch, they remove the fun time, then back to the home, start it again, brushing the teeth, wear the liner, then maybe 80 hours per day. But it depends. But just a little bit reduce the time is better to the motivation for the patient, especially the young generation. That is very nice.
For sure. Teenagers do not like to be told what to do. So if you tell them that, oh, you're free during these hours, I'm sure that freedom will motivate them to be better with their aligners when they're not in a period of freedom. And by the way, Dr. Stefan was from Germany. Guten
Germany.
Tag.
Vielen Dank. Vielen Dank, Stefan.
Okay, so let's move on to another question. We have a question from a Japanese doctor. And
Dr. Sumida
yes,
Sensei.
Dr. Sumida Sensei says,
Sumida Sensei,
when
Sumida Sensei, Dr. Sumida will be watching my YouTube channel for the Japanese version after online seminar, after this channel.
Yes, I'm sure. Yes, we do have a Japanese discussion after this as well. So please come join us.
Watching my YouTube channel too long.
Well, thank you for being a great supporter, and we're glad that the quality of our content motivates you to be tuned in. Dr. Sumida's question is, when were the wisdom teeth removed?
This patient is end of the second molar distalization, and about around 16 years old. So before the 16 years old, so still wisdom tooth, but if going to the second molar distalization is possible. So no need for the early time for the extraction upper wisdom tooth. So このぐらいの年齢の時は16歳ぐらいまでは大丈夫だと思います。第二第9子を送っている時に知子も一緒に行けると思うんで、それは my recommendation is if you want to upper molar distalization, is still wisdom tooth is there, is possible if control second molar distalization and the follow up to the wisdom tooth. My extraction time for the wisdom tooth is around after 60 or 70 years old. Thank you.
Great.
ありがとうございます。
Thank you very much. Thank you very much for your question, Dr. Sumida. Okay, we are back to our wonderful Chinese doctor, our very active participant in the chat, who says,
谢谢。
why do you rarely do class 2 elastics on precision cut in molar distalization cases?
A very nice question. So the very important thing, this is I want to avoid for the molar anchorage loss. So support anchorage loss at this time is using the elastic is more safety. If you without any elastic, just a little bit dangerous. Molar distalization, but the next aligner is an aligner some of the time anchorage loss happen. That is very sad. Then so the more safety way is control molar distalization, then keep it so that we don't want for the anchorage loss. At this time I use glass elastic. Thanks a lot, wonderful question. 谢谢.
Excellent. Thank you very much. Yes, indeed. All right, let's take a few more questions before we sign off for the evening. Our next question is from Dr. Philippe. Hello, Dr. Philippe.
Thank you.
So Dr. Philippe was watching very closely, and he noticed that you didn't use attachments on the molar to distalize. So when do you use or don't use attachments when you distalize? How do you make that decision?
So three things is very important thing. I already told you for the specialty upper molar distalization time, I never place on second molar. So the reason is three. It's one is a crown is very big, and the aligner is easy to gripping. Then so the control distal movement. This is my first reason. Second one is a very difficult to placement for the attachment. If just a little bit different position place on the attachment, already started to unfitting. Okay, so the very important thing, aligner fitting is better, tooth control is good. If just a little bit unfit, aligner not good fitting, unfitting is not good for the distal movement. Very important thing, so we have to think about aligner fitting is more better. At this time, if placed on the attachment, second molar, very difficult to place on attachment precisely. If still there, bodies is already started to unfitting, then I don't use any attachment second molar. Third one is very difficult to brushing. Some of the time very easy to happen for the caries. I don't want for the during orthodontic treatment time is a patient caries. I don't want like this. So the easy to brushing and aligner fitting is better, and the crown is very good shape. I don't place on any attachment. Thank you.
Okay, another wonderful piece of wisdom. We love to hear these 3 golden rules or 4 golden rules when you have them for us. Thank you so much, Dr. Kenji. And thank you, Dr. Philippe, for your wonderful question. A couple more questions before we sign off here. How long did it take? We have a question from PCDEGPS, who is a Japanese dentist.
This is the Japanese. I am Japanese. Okay. Could you talk to the Japanese language? No problem.
No problem.
How long?
How long did it take for distalization in this case?
The time, right?
Yes.
How long did it take for distalization? Is it millimeters or take a time?
Let's do both. Let's start with let's say both. How many millimeters and how much time did it take?
Okay. So the specialty this patient is 3.5 millimeters, and the time is 1.5 years will be. But only focus on the second molar is not to 1.5 years, because the aligner is one aligner 0.25 millimeter tooth control. The 4 aligner is we can control 1 millimeter. If 3.5, about 12 aligner. Less than 15 aligners. Yes. ありがとうございます。
Okay. Thank you very much. And let's take one final question before we sign off today. The last question is from the Dr. Kudo from Prison Tower Dentistry. Thank you as always for joining us. ありがとうございます。
Prison Tower. 素晴らしい。
And his question is, how do you think about stage 1 treatment and stage 2 in younger patients? Does it depend on the patient? What do you think?
How do you think about stage 1 treatment and stage 2 is okay, so the stage 1 is a specialty focus on the cheap complaint, and we have to think about is anchorage, keep the anchorage. So very important thing initially, so some of the time, so the young generation not good motivation, so we have to check the patient is mind. Okay, so because aligner orthodontic is a very important thing, the patient compliance, the combined to our approach is good for the result. So initially, so the eye planning for the molar distalization, but is not too much distalization is better because we some of the time we have to think about check for the growth. Okay, the too much distalization is not good. Then so initially we have to check the growth. Now initially is 息治療 okay, so okay, so the phase 1, so the phase 1 is mean 息治療 okay, 息治療 mean is mixed dentition is a baby tooth, adult teeth is a mix at this time. So my focus is 3. So the initially is a molar position. The second one is anterior teeth alignment, and waiting for the growth and waiting for the premolar eruption. The phase 1, so my goal is a molar position, sometimes distalization, sometimes expansion, and alignment anterior teeth. Then waiting to the second phase.
Okay. Well, thank you as always for being an engaging audience member, Dr. Kudo. It's always wonderful to have you here. And let's take one final question. We're over time, but we do have one question left. So let's take this from Dr. Mirza. Hello, Dr. Mirza.
Hello, Mirza.
Dr. Mirza from Bosnia and Herzegovina asks, what step values do you recommend for moving and rotating the tooth?
Okay, moving and the rotation the tooth is a rotation time is a eye solution is a two thing. Initially place on the rectangular vertical attachment, and second one is a create a space, then started to rotation. That is very important thing. So many of the doctor is started to rotation, so the without any create a space, very tight, cannot for the insert for the alignment. The very important thing initially create a space. Then started for the rotation is more safety and more predictably tooth movement. I definitely recommendation.
Okay. All right, ladies and gentlemen, thank you for joining us on this hot evening in Eastern Japan. It was unseasonably warm today, but the warmth was not just in the weather, but in your hearts and in our hearts as well, because you joined us for our 5th YouTube Live International. For those of you who are new to us, we do this 2 times a week. Our next show will be on Wednesday, as we usually plan. As long as we don't have any schedule conflicts. And please take time to like and subscribe this video. Your liking and subscribing to this video makes us more visible to more different doctors. So please, your support, if you enjoyed this content, if you'd like to see more, if you'd like more people to join, have more intellectual conversation within the chat, please like and subscribe and help us get our name and our brand out there. So ladies and gentlemen, we've had another crazy week in this crazy world of ours, and we hope that our conversation together has given you some sense of comfort and a bit of relief in the form of education and learning from the stress of your everyday lives. Kenji, do you have anything you'd like to say to our audience before we sign off?
Yes, normally at this time I had a lecture in AAO in Atlanta. So please, for the many of all of the orthodontists of the world orthodontists, please watching the AAO webinars. The AAO is the biggest for the conference in the world. So I hope for the next year I want to see in AAO the real face to face. But this year is a very dark time, so that everybody using the webinar is we can use for the technology. Okay, but please for the keep the mind is not to the dark time. You can do it. You can win for the coronavirus, and I want to give so that we give Robert and me the give to the energy for your wonderful colleagues and friends. So please watch next time. So that see you soon.
Yes, see you all soon. Take care until then. Thank you very much, everyone.
Bye bye. See you. Thanks a lot, Robert. Thank you.
Thank you, Dr. Kenji. Thank you.